A very good evening, dear doctors. A very warm welcome to all of you to online dentistry once again. Kindly wait for a few minutes while we enter all our participants. Online dentistry is always happy to help you for various things. For any queries or any doubts, kindly visit www.onlinedentistry.in. Your patience is appreciated. Kindly wait for a few minutes while we enter all our participants. We'll be starting our sessions very shortly. Once again, a very good evening to ladies and gentlemen. A very warm welcome to online dentistry. Before we move ahead, we'd like to show you a short glimpse of the year's journey in online dentistry. Thank you, everyone. As we all know, that our motto is to redefine dental education. Well, our numbers suggest that we have established our firm in the year 2008. In these 13 years, we have conducted 122 offline courses and a staggering amount of 500 plus online courses. We are a very happy family of 20,000 plus members globally. Well, when it comes to online dentistry, we all know that dental practice and the management have been changed in various ways. And the reason behind that are these two mighty gentlemen. First is Dr. Professor Jobby Peter Sir, MDS, Professor and Head of the Department Pediatric and Preventive Dentistry, Anu Dental College, Head of the Academics, Online Dentistry. And Dr. Binuti Abraham Sir, Kerala Dental Clinic, Alua, CEO, Online Dentistry. Well, when it comes to online dentistry, the first thing that pops up in our head is sessions. We are going to conduct our first offline session in 1.5 years, that is on 23rd and 24th of October, that is on orthopedic movement. And I'm very happy to announce that we are sold out on this particular session. But we have other sessions coming up on 11th and 12th of December, that is twin block. And we are very happy to be announcing that we are opening our Chennai branch very shortly, that is next month, and we'll be conducting a 3-day offline program. So we shall see you all there. The next coming up session is on oral lesions for general practitioners. We all know that how oral lesions are definitely misdiagnosed a lot of times. Oral pathology is an integral part of our dental practice, and choosing your pathologist is like hitting the right bullseye. So all of this will be covered in this particular session that is coming up on 31st of October. Do not miss this. The next session from online dentistry is clear aligners. How aesthetically pleasing are these clear aligners? Is something that is almost invisible to the normal public. Well, everybody is afraid of braces due to aesthetic reasons. Now, clear aligners solves all these problems. So all the protocols and management are described in this particular session, clear aligners in your clinical practice. So tune in to online dentistry to register yourself for the same. Well, online dentistry is always there to help you. So kindly ping us on these WhatsApp numbers or visit us on www.onlinedentistry.in. Well, you all must be wondering why we have conducted this particular session on Saturdays. As we all know, we are there with you on Sundays. Today is a special day. Today is World Anesthesia Day that is observed on 16th of October, which was marked as the first successful anesthesia administration, that was diethyl ether. Well, it was administered in the year 1984, and since then, the face of medical science has been changed. To honor that and to honor World Anesthesia Day, we are conducting this session, Cases Under General Anesthesia, All That a Dentist Must Know, with Dr. Vinod S. Nair, sir. Before we go ahead, I'd like to give a small introduction about Dr. Vinod S. Nair, sir. Sir is presently a consultant at the Department of Anesthesiologist and Critical Care at Sabine Hospital and Research Center, Kochi. Well, he's been there since the year 2011. Sir graduated from M. Ramaiah Medical College and he specialized in his field from Government Medical College, Mysore. He has served as a senior resident in Amrita Institute of Medical Sciences, Kochi. He is a present secretary of Indian Society of Anesthesiologists in Malanath City. He's also the present treasurer and former secretary of Indian Medical Association, Kochi. He is a member and certified trainer of Indian Resuscitation Council. Sir conducts regular workshops on compression-only life support for general people and ALS and BLS for medical professionals. Sir had trained various students for the same. Sir, we welcome you wholeheartedly to online dentistry. It's an honor to have you here. Ladies and gentlemen, Dr. Vinod S. Nair, sir, on your screens.
Thank you. Thank you for the kind word. Thank you all. Thank you, online dentistry. Thank you, Dr. Joby and Dr. Bino.
So you can start sharing the screen, sir.
All right. Okay. Just give me a second. Hope I am visible.
Yes, sir.
Right. Thank you. Thank you for your patience waiting. There is some technical issue I faced with the laptop. Um, um, Let me start with greetings from Malnad ISA, chapter and Sabayan Hospital Research Center, Moatupura, where I belong to for the past years or so. It is indeed an honor to represent Anesthesia fraternity on this day, when we're commemorating the first successful demonstration of anesthesia by W.T. Morton. It was done way back in 1946 at Massachusetts General Hospital, Boston, US. You can see an image of the event. Morton had used ether then, but one must not forget a dental surgeon, Horace Wells, who conducted a successful extraction of teeth by himself. By himself in the sense, by after administering nitrous oxide, he requested his associate to remove his teeth. And he was successfully removed. He was impressed. He tried public demonstration, which was failed due to faulty delivery of nitrous oxide, which was a disaster at that point of time. But anyway, W.T.G. Morton pursued after as well with his experiments with the different agents, and ultimately he succeeded with ether. So that's an interesting history. The point is, one cannot ignore the role of young dental surgeons in the 19th century in the development and evolution of anesthesia. There has always been a part of dental practice delivering anesthesia. Till recently, up to say 2000 or 2001, dental clinics were used to, and general anesthetics used to be administered in dental clinics in UK. Of course, there were side effects and complications. Ultimately, the critical care access and a lot of things happened. They had to withdraw from that. Now, general anesthesia is recommended only when there is a critical care facility is available immediately. So let's see scenarios requiring general anesthesia in dentistry. You must be aware of this thing more than me. Mostly, it's young children who require anesthesia. The cooperation of the patient is very important. Then another category is behaviorally challenged patients. Patients allergic to local anesthetic agents and complex procedures, like maxillofacial surgeries. They require general anesthesia techniques. Out of this, young children and behaviorally challenged patients constitute around 75% of the patients requiring general anesthesia in the dental surgeon's perspective. And I think most of my talk will be covering the pediatric anesthesia aspect as well. As well. So before getting into that particular topic, let me tell you, as a practicing dental surgeon, I highly recommend to identify a facility in your nearby locality with a proper OT setup and anesthesiologist facilities and other, as we go through, we will get to know what are the gadgets we require and what are the precautions we need to take. So, more than that, the workflow one need to be knowing about. You should be aware of it. So, in an anesthetic point of view, our approach, our involvement starts with the pre-anesthetic evaluation. Really sorry about that. Is my screen visible?
Not yet, sir. You need to share the screen share, sir. Yes, so we can see your slide, sir. You can go to the full screen mode now, sir.
Yeah. Okay. Thank you. I think I will stick to this slide. I mean, this view. I think this will be better. Really sorry about the technical issue. So let's come back to the point that is pre-anesthetic evaluation, where we try to get to know the patient better and try to build up a rapport. So particularly in pediatric point of view, we are concerned more about the developmental history. Is there any associated illness, the vaccination status, then acute infections like cold, cough, etc. Of course, this follows a general physical examination with a special focus on airway assessment. See, as anesthetist, we share airway with the surgeon in dental cases. So we need to be doubly sure about the airway. Once the process of securing airway is done, revisiting the airway to check or any manipulations would be extremely difficult, as we'll have to stop the surgery in between. And so we have to be very sure about the airway, especially in dental cases or maxillofacial cases. Then sometimes you need to clear consultations with particular specialists like the neurologist or pediatricians, depending on the condition, the medical situation conditions of the patient. Then, of course, lab investigations, which include regular hemogram, then bleeding time, clotting time, renal function test, liver function test. Then, of course, ECG, X-ray. All these things are required, but usually tailored to patient status. Not all require all investigation. It's an opportunity to discuss the details of the anesthesia plan with the patient and their relatives. It helps to clear doubts and alleviate anxiety, and is easier to obtain the informed consent. So we also advise regarding the fasting guidelines and medication at this point of time. Usually we require around 6 hours of fasting, especially towards solid foods prior to administering general anesthesia. It is for 4 hours for milk, say tea or coffee and things like that, and for 2 hours for clear water or say like a glucose water. There is a present guideline. Then we get to meet them on the procedure day, and we review the status of the patient once again. And next, we prepare the operation theater, which is of utmost importance. So we load the drugs, we check the gadgets, monitors, anesthesia workstation, everything we double check to ensure the safety. Further, we administer a pre-medication to alleviate the anxiety. Then anti-anxiety agents like midazolam we give. Anticholinergic agents, especially glycopyrrolate or atropine, we give in order to suppress the vagal tone and to decrease the secretions as well. Analgesics is another component, mostly paracetamol or opiates. Then we give antiemetics as well, because most of the anesthetic agents and analgesic agents are emetic in nature, and patient may omit. So that is another thing. Then sometimes we give proton pump inhibitors or H2 blockers like ranitidine or pantoprazole in order to suppress the acidic nature of the gastric secretion. Here we are really worried about the aspiration of gastric contents while administering anesthesia. What happens is, under anesthesia, the protective airway reflexes are suppressed. So there's a high chance of entering the gastric contents entering the tracheobronchial tube. So that is one thing we are really worried about. So that's about the pre-medication, and we get the patient inside the OT. We connect the monitors, essential monitors, pulse oximetry, ECG, end-tidal carbon dioxide, non-invasive BP, temperature monitor. This is standard worldwide recommended monitoring. This is the monitoring standard recommended by ASA and or other anesthesia associations. Following this, we will induce anesthesia. That is, see here, the practice is called balanced anesthesia technique. The induction, we induce anesthesia using a particular agent. You maintain with another set of agents. See, as I told, we give midazolam in the beginning, like as a pre-medication at an anxiolytic dosage. It can be used as a single agent for induction as well. Similarly, fentanyl, like an opiate, it is used as analgesic, but at a higher dosage, it can be used as an induction agent. But the problem is, if you use a single agent for induction, the dosage requirement will be so high, you'll have to worry about the side effects. The side effect profile also will increase. So the concept of balanced anesthesia has emerged, where we use different agents to meet different targets. That is, to obtain the anxiety, to alleviate the anxiety, we give midazolam. To alleviate pain, we give fentanyl at a lower dose. So the anesthetic requirement for the induction for induction of anesthesia, the requirement dosage will be much lesser. We have two modes there. That is, we can induce with intravenous induction agents or inhalationally, like fluorine or halothane. We can use them. We use inhalational agents. Mostly we use in very difficult airways or in pediatric patients where there's a difficulty in getting IV line. In only such cases we give inhalation. That's another. It's a bit complicated technique. We need a lot of manpower to handle that. So mostly we do intravenous induction. That's a popular method. And the agents we prefer to use are propofol or ketamine. Thiopentone, etomidate, etc. are not used nowadays. Here, then comes to the question of airway management. What happens after induction? Induction is so deep that takes the patient so deep that they may not be able to breathe by themselves. So it is our duty, the anesthetist duty, to ensure the adequate oxygenation and ventilation. And secondly, we need to protect the tracheobronchial tree from aspiration as well. So how do we achieve that? We have different gadgets. We have mask, bag and mask. We have airways. We have tubes which we can pass through the pass into the trachea and ensure adequate oxygenation and ventilation. So, and in the dental cases, we have to do a nasal intubation. So we can see here. Here we can see a curved tube. It's not very clear, I suppose. See the tube is curved here. This is the nasal endotracheal tube. So we introduce the tube via the nares of the child or patient, and we do a laryngoscopy. Visualize these are the laryngoscopic blades. Using that, this is a video laryngoscope. This is one latest edition where we can see very closely and with a magnified image of the larynx and the passing of the tube, and we can even record and anybody can. It's a latest edition among the gadgets, and we have different. So basically, we use a nasal intubation for dental cases. So we can throat packing is essential. This is the Muggles forceps. We use this Muggles forceps to pack the throat after passing the tube, because even though, see, in pediatric patients we cannot say always we can may not be able to use cuffed endotracheal tubes. Many times we have to settle with the plain endotracheal tubes where there will be a leak around the tube and the trachea. So we need to plug it with gauze, sterile gauze. So we use this after introducing the ensuring the airway. We make sure we pack the surrounding area to minimize the leak. Of course, we need to prevent surgical, the blood and or the getting into the endotracheal tube as well. So that's how. So talking about airway, the role of muscle relaxant comes. We can intubate with induction agent itself, but as I told you earlier, the concept of balanced anesthesia defines different drugs for different roles. So to achieve muscle relaxation conducive of endotracheal intubation, either you have to give a high dose of induction agent or you can use a muscle relaxant agent. So the commonly used agent is succinylcholine here. It's a depolarizing muscle relaxant. It's very short acting. It has its own side effects and all, but I am not getting into the details of the pharmacology and things. But it's an agreeable drug. That's the best way of putting it. But there is no other agent to challenge its position in terms of the short duration of action and other aspects. So succinylcholine we use for intubation, and non-depolarizing muscle relaxants like atracurium vicarium is used for maintenance largely, but we can use it for induction as well. Only thing, it will take some more time to achieve the desired relaxation time, and the duration of action also is 30-40 minutes at last. So that's about the muscle relaxant. So once we intubate and secure the airway with throat pack, then comes to the maintenance aspect. We hand over the table to the surgeon, the patient to the surgeon, and so we will be concerned about the maintaining the anesthesia for the procedure, where we'll be ventilating the patient using bag or using ventilators. Most of the newer hospitals have anesthesia workstations where there is an integrated ventilator with the anesthesia machine, and we use a volatile anesthetic agent along with oxygen with air or nitrous oxide. Remember, Horace Wells ages ago started with nitrous oxide, and we are still using nitrous oxide, which is a very good analgesic agent. But still, there is controversy regarding its usage. There is a point of view that nitrous oxide may not be that very good, but many people use nitrous oxide. And in my hospital, we stick to oxygen and air. Even though we have nitrous oxide, mostly we stick to oxygen and air. Nitrous oxide only if it is necessary. And a volatile anesthetic agents, sevoflurane, isoflurane, halogen, etc., are used for maintaining the anesthetic duct. Then other parameters, IV fluids, warm air blanket, then adequate padding. All these are important, and it's up to the anesthetist to look after all these things. And a meticulous monitoring of all the parameters. As I mentioned earlier, that ECG, heart rate, pulse oximetry. Apart from that, there can be mishaps, like the tube may get disconnected. You never know. Once the table is set, surgeon and the assistant approach the patient, and the cover it may not be visible. The tube and tubings may not be always visible. So we need to be very sharp. So meticulous monitoring one can never underestimate. And by the time the surgeon finishes, we stop the volatile anesthetic agent. We give neuromuscular block reversal agent, which is neostigmine and acetylcholine stress inhibitor, along with antimuscarinic agents to avoid the side effects of neostigmine. So we give atropine or glycopyrrolate along with that. We have to ensure adequate recovery of the muscle power. Thorough suctioning is essential before removing the throat pack and extubation. So that's how we wind up the case. One important aspect is to ensure analgesia in the postoperative period. We approach again, like as I told about balanced anesthesia, again about analgesia also the approach is multimodal. So we tackle the pain pathway at different levels. So that is through a local infiltration of anesthetics. I mean, local anesthetics like lignocaine and bupivacaine. You must be familiar with most of the dental procedures nowadays are conducted under local anesthesia. So the local infiltration of local anesthetics is one area, along with paracetamol or NSAIDs and sometimes opiates. That's how the analgesia plan works out. Then, of course, monitoring the vitals, IV fluid, oxygen supplementation. Usually, within around 3 hours, the patient will be out of the depressant effects of the anesthetic agent, and we can start diet, soft diet. Most of these cases are daycare procedures, and within 24 hours, we can maybe another 3 hours or 4 hours. Postoperatively, 6 to 7 hours, we can discharge the patients. Of course, they have to meet certain criteria, and we have to advise them regarding any warning signs and all these things. All these things are handled by our postoperative unit. So the successful conduct of anesthesia is always a teamwork. It must be evident from, already that a single person cannot do all these things, but definitely anesthesiologist takes the is the team leader of the perioperative care. So he is the one who coordinates all this, and with the help of a dedicated nursing staff and anesthesia technician. I told you about the machines and monitors. There was an era, operation successful, patient died. Most of the time, it was told as a joke. It was a fact as well. Till late 80s, anesthesia techniques were very, very, primitive. The technological advancement helped us to alleviate most of the troubles and problems, especially regarding the monitoring aspect. We have very reliable monitors now to monitor the vital parameters, and the machines. The anesthesia, I told you about anesthesia machine, delivery of anesthetic agents. You should be sure about the amount of anesthesia. Earlier, people used to give, put in a flask and let them smell through folded kerchief and all, like you see in movies, like chloroform. Somebody puts on the mouth and patient collapses like that. That was once upon a time. Those are the practice. Those are the things practiced. But the sophistication, the technological advancements enabled us to give to deliver precise amount of anesthetic agents with very careful monitoring, and that has made a difference since 90s, or by the end of 20th century. The anesthesia related complications and mishaps are extremely rare, and whatever happened are mostly related to human error. So the technical error side is more or less, of course, there will be issues which are it cannot be avoided, but the technical errors are almost nil. We can say the safety features have improved a lot. Gadgets, another thing. Am I audible?
Yes, sir. You're audible, sir.
I told you about the gadget, video laryngoscopy and things like that has eased the airway, the difficult airway scenario as well. A lot of things. So let me give you a walkthrough through the workflow in our hospital, the combined hospital, Movatipuzha. So here is the pre-op room where we receive the patient. verify the identity, all those, cross-check the vitals, and cross-check the data, and check the vital parameters. Then pre-anesthetic drugs as well we give. Then there is a wash area at the entry, which is mandatory for those who enter the sterile zone. So our senior sister was grateful enough to help us with this video. This is how during the COVID times, I think most of the people got familiar with the hand washing technique. Oh my God. Yeah. So this process we repeat. Ideally, at least 3 minutes we should be washing. You can see the entire forearm and elbow is being washed. It's unlike the common hand washing technique what that is being popularized for the COVID-19 preventive measures. In OT, it is slightly different. The basic steps are same, but we do wash up to the elbow and forearm. This is for the sake of PG sampling. Most of the seniors must be familiar with this. So that's about the wash area, and we enter the OT. As I told you before, this is our anesthesia ventilator, which has a very precision anesthesia delivery system, and we have the monitors, all the accessories, all the drugs loaded here. I have the airway cot, emergency medicine. So this is a mechanized table which can be positioned as per the surgeon's requirement. This for the completion sake, there's a wash and storage area. There's a storage sterilization department, that is all the autoclave machines and all. So last but not the least is the post anesthesia care unit at our hospital, where we have a ventilator, trained staff, and there's a defibrillator, all the airway cart, emergency drugs, everything is stored there. So you have to be ready for any eventualities, because post-operative is the place where you leave the patient after anesthesia. You need to be very sure about that, because inside the OT, to a great extent, the doctor is there, the anesthetist is there, everything happens in his presence, and you shift out the patient. You have to be very sure about the patients you are entrusting your patient with. So you have to be very confident about the post-operative care unit actually. This is a video. It's a pediatric. I didn't get the video of. Yeah. This is some other pediatric case. It's not a dental procedure per se, but still it helps to show the teamwork, and I'm mask ventilating the patient. Just kept it aside. But I'm doing a laryngoscopy. My assistant, one technician is helping me with the airway management. There is the intubation. There is another technician standing next to the IV line who is giving the drugs and keeping an eye on the monitor. You can hear the monitor sound. So now I intubated, connected the tubings. You can see my anesthesia machine on the back. The technician has come to other side. So this is what I meant by teamwork, because I can't afford to leave the tube or the bag. So I need somebody to help me. To ensure the position of the tracheal tube. So it's a well orchestrated event. The next step is ready. The technician is ready with what next and what the backside you can see a little bit of the monitor, the ventilator. These are the ventilator parameters. So now I'm fixing the tube. So once again, we check the air and rate. As I told you, so once I fix and leave the patient to the surgeon, then accessing the patient again will be a bit difficult, airway. So you need to be doubly sure about it. So that's the video about it. So it's time to conclude. I must thank Online Dentistry and Dr. Jobby Peter as well as Dr. Vinu for giving me this great opportunity to address you all and helping me with the slides actually. Thank you. Thanks a lot.
Thank you so much, sir. It was indeed a great session, enlightened us all about anesthesia. Before we start our Q&A round, I'd like to invite Dr. Jobby Peter, sir, for moderation and concluding the session. Sir.
Thank you. Thank you, Dr. Vinod, sir, for this session. When I had discussed with him about this, he was so enthusiastic that I'm addressing dentists across the globe. He was very excited and he readily accepted our invitation, and I must salute the work that you have done to make it so simple for dentists. But that was our concern, because we are people who do not know about all those things, and you made it very simple, very practical way how we have to approach this. At this point, again, I congratulate, thank you and your team for giving us this opportunity and listening to you. Anesthesia or general anesthesia is a doubtful topic for many dentists. Many times they ignore it, or many times they may not accept it because they think too much about the complications, and they do not think the better perspective of that. For example, even a simple extraction can be complicated. You give a local infiltration, that can also turn out to be very fatal. But it is not turning out to be fatal because you are an expert in that. Imagine you are not an expert and doing it, definitely it can end up in a complication. So when we, exactly the same thing is with an anesthetist who is an expert and who has got a dedication and a teamwork. He will be doing it daily, maybe 15 to 20 cases, he will be doing it and nothing happens. Exactly how we does extractions or do complicated surgeries in our dental clinic, nothing is happening and we are successful because we are an expert. So all of us are an expert in this field of dentistry. We are not an expert in field of anesthesia. Only thing is we get connected with them. So I suggest, as sir suggested, you have to search a good facility near to your clinic or locality where you are confident. Go into that area, go into that, walk into that hospital, talk to the anesthetist, have a good rapport with the anesthetist and tell your requirement, and then start interacting, and definitely it can change your practice a lot. So that is my just concluding remarks with the respect to dentistry and general anesthesia, which we cannot ignore. There are situations which you might require. Many of the time, even the senior most dentist doesn't know whether even the pediatric dentist is taking the case, or anybody who's oral surgeon is taking the case, and he's doing orthodontic surgery, everything is done, then only the senior most practice in dentist comes to know. It should not be that way. It should be a team where everything is been monitored, everything is known, and you, the practicing dentist, should take lead in saying that I have an anesthetist, or if you have a team, let us integrate with the team and let us work together so that I can promote, I get confidence in the anesthetist, confidence in the center, then I will promote. I will tell my patient, if you are scared, if you have a difficulty, if that cannot be done, there is an option for me. Nobody cannot explain better than the practicing dentist. He is the king and queen of that patient. So every patient, parents trust the practicing dentist. And if that dentist say, if the specialist is with me, we are one, the patient will accept it. It's very important that practicing dentist should understand this, and this can be another tool in your kit, in your practice section, where you manage difficult cases, complicated cases, by cooperating with the hospitals. Thank you so much, sir, for this enlightening session. Now we are open for any question and answers. So you can put in the chat box so that we can answer those questions within our limited time frame. So sir is very busy from the hospital. He is on duty because I know how busy he is, but still from the hospital, he is in the hospital. He has got full night for the duty are there. So please make your questions very fast. Sir will address that, and then he will wind it up. Dr. Devika, any questions are there? You can start it. Thank you so much, sir, once again.
Thank you, sir. We already have a few questions in our chat box. Shall we begin, sir?
Yes, yes.
Yeah, so the first question is, what are the pre-anesthetic evaluations necessary for pediatric patient treating under GA?
Well, pediatric patients generally without any comorbidities, like any associated illness is not there, they require a simple hemogram itself. HB, CCDC, ESR will suffice, along with, of course, serology and the COVID-19 test as of now. So apart from that, we don't need any other evaluation. But of course, if the child is having a history of any recurrent chest infections or like any like congenital cardiac disease and things like that, we'll have to investigate that, like maybe with an echocardiogram or a chest X-ray or things like that. So apart from that, we don't need a regular healthy child that will require more than hemogram, the grouping maybe ECCT, of course, then serology.
Thank you, sir. The next question is, if the patient had undergone some other procedure under general anesthesia, and after a few months, he wants to undergo a dental procedure under GA, what is the interval period indicated, number of months, between two GA sessions?
Well, that is actually there is no gap as such. It is. It all depends on the evaluation of the patient. If the patient is healthy, one anesthetic agent given maybe 2 months ago or 1 month ago, it doesn't matter. For that matter, like we are expecting the anesthetic agent. Generally, whatever the agents we use nowadays are ultra short acting. So we are not expecting the anesthetic agent effects to persist for say more than 48 to 72 hours. So that's not an issue in really. See, many times apart from you leave the dental part, we do cases. Say, for example, say maxillofacial surgery, the flap surgery. The flaps we are doing it for say so many hours, maybe like even more than say 72 hours. I mean, a single particular multi-stage, I must be knowing that. It will take a lot of time. So such cases, sometimes they shift out the patient to post-operatively. They may require a redo anastomosis. They will rush back into the OT. There is no question of a gap there, right? We take it up. We tailor it according to the situation. Suppose the patient is already sedated. Fine, we don't need to give extra dosages. We may need a little bit of top-up anesthetic agent. Okay. I'm not telling, I'm talking about an emergency situation. An elective case, it doesn't require such a gap at all. I mean, in the sense, there is no fixed time frame for a previous say they had 6 months ago a surgery. It doesn't affect at all. We can give say, at any point of time. That's the only thing we need to tailor the medication.
So, sir,
primarily, but being an elective case, we'll be a bit more careful about, say, suppose the child is sedated or depressed. So why do you want to take up the case as an elective case? We may like, okay, let the patient wake up, or let's see what is happening. We don't know exactly why the child is sedated, or is it any adverse event, or is it taking a longer time to recover from anesthesia. So that is another thing. Say, for example, the case I saw just now, I showed you just now, was about a circumcision. The child, we did circumcision. So then, say, suppose suddenly the patient's dentist realizes the patient had some caries. Let us utilize this anesthetic opportunity. This opportunity can remove the teeth as well. Sometimes, multiple procedures combine and do. But they can do it in the single setting. But once we extubate, leave the patient out, it may not be may not take up for say 72 hours or something like that. Because being an elective surgery, we'll have to give time to recover and take it up again. So 72 hours may be a reasonable time, but there is no hard and fast rule.
So, sir, if the patient is healthy, I mean, it's like not like a week after, if an emergency come again, you might have to do it.
Yes, sir. Of course.
Yes. Thank you.
We'll have to take up.
Yes.
Especially, see, my center is mostly a gynecological center. So we take up cases on a regular basis, which are, say, for example, a patient comes with cesarean. We once the surgery is over, suppose I have did it, usually we do it under spinal. Suppose I have done it under GA. And later the patient maybe develops bleeding or she needs to be, operated again. We'll take it up. We'll take her up. We cannot wait for her to come out of the anesthesia or giving the gap. The only thing, we tailor the drugs and dosages. We adapt to the situation. That is the thing.
Thank you, sir.
Thank you, sir. So the next question is there any particular thing to be done before performing GA in special children?
Special children, all children are special. That is one thing. But I think it's a differently abled.
Yes,
children.
differently abled. Yes, sir.
Mostly,
Differently abled children.
In such cases, we need to see most of the time autism, learning disabilities, all those things are there. One thing is cooperation, ensuring getting an IV line onwards, it will be a task. It will be very difficult to convince the child and get them to do what we want, especially with the children with special needs. We need definitely we need pediatricians and neurologists consultation for medical legal purpose, because we are not alone in this show, because we need to involve them at some point. We may need to involve them at some point post-operatively if required. So we cannot suddenly send, okay, they suddenly develop something, please come and have a look. It's always better to involve them, take their consultation. And another thing is we need to consider the medications. Some of the medications do interact with anesthetic agents. Some anesthetic agents are contraindicated if the child is having epilepsy and things like that. So such cases, we need to be a bit more careful. And we do take up if the patient is stable. Like, say, for example, say epilepsy. In children, epilepsy may not be very obvious. Like, it can be absent seizures. Only an EEG can detect. So if the child is having a regular follow-up with a pediatric neurologist, only he will be able to know whether the child is having, because they will monitor the EEG and things like that. So if the child has developed seizures under anesthesia, he'll find it difficult to extubate. It will be difficult to come out of the anesthetic agent, because we are using mostly CNS suppressants. Almost all the anesthetic agents are CNS suppressants. So seizures are unlikely, but in an uncontrolled seizure, a child with uncontrolled seizure disorder, it will be very unpredictable. We cannot say whether the child will see. Usually, the procedure ends and we stop the anesthetic agent. We expect the child to come out of anesthesia in a reasonable time. So it should be ventilated out. There is a pharmacodynamics regarding that. Because pharmacokinetics and pharmacodynamics. So it has to come out of the system. That's a reasonable time for the patient to come out of the anesthetic agent. But in a child with an uncontrolled epilepsy and things like that, it will be a bit difficult to predict. We don't know how the child will be responding to our medication. So that kind of patient, it will be better to do higher center, like with a neuromon, like say Amrita, it would be better. So that is about the special needs.
Thank you, sir. The next question is, do we need to administer local anesthesia in our procedures while the patient is under GA? Will that help in reducing post-anesthetic pain?
Definitely, yes. First thing, under anesthesia, before giving a local infiltration helps to prevent the stimulus, the painful stimulus, the noxious stimulus itself. At onset itself, we can prevent the stimulus. That is the primary entry point of the pain pathway. So we are blocking the receptor at the receptor level itself. Causes a lot of difference in preventing, in reducing the analgesic requirement in the postoperative period. So I strongly recommend giving local anesthetic injection before doing the procedure, and maybe we can repeat it if necessary at the end of the procedure. That will help in again analgesia. I think I talked about the concept of multimodal analgesia. So you tackle the pain pathway at different points.
Yes, sir. Sir,
yes, sir. And there is a concept of preemptive analgesia also. There is the thing I told you about. Before a noxious stimulus starts, you block the path. So the intensity of the pain intensity will be much lesser, and your intraoperative and postoperative analgesia will be far lesser. So it is very, very highly recommended.
Yes, sir.
Only if it interferes with the surgeon. The plane, or sometimes surgeons will not be very happy with incisions. They may, once you infiltrate subcutaneously, the plane may get disrupted. Sometimes the visibility. Other than that, we don't. In fact, we recommend that.
Yes, sir. Sir, remember, sir, none of our cases post-operatively, a patient goes to nice sleep and they gets up and the mother calls and tells her, everything is done, can I discharge? I get the call back, can I discharge? Because the reason is that what you said is, before that I used to ask him, sir, can I give an LA? Sir, go on. And any procedure like a pulpectomy or extraction or root canal, we give an LA to anesthetize the particular teeth or particular area we are working out. And that really works. The patient is comfortable and sleeps after revival, and he will never get any call for that purpose, and also I never get any call, and parents are also happy, and after that they discharge and go, when can I go, my child is very fine. That's very true. Thank you, sir. Thank you for that.
Thank you, sir. The next question is, maximum hours recommended to undergo a full mouth case under GA in pediatric cases.
Full mask, pardon?
The maximum number of hours recommended to undergo a full mouth case in pediatric cases.
I think that question is towards me, sir. As a dentist, a pediatric dentist, I should answer that. Sir can't say.
Yeah, please.
Because there was 3 hours. Sometimes, remember, sir, we had taken 3 hours. Sometimes we have taken 2 hours. Sometimes we have taken 1 hour. Then he come and ask me, Joby, it's over? Yeah, it's over. But he can tell, sir, one thing, see, all our postgraduates from all over the globe are there, sir. What we require is one genuine thing is required is like, how long for a child or a person we can hold under general anesthesia, like especially a child under 13-14 years, how long is safe enough so that we can plan our procedure and well plan before the anesthetic procedure itself, we can well plan. So you have any recommendation that how long is the, like for you, there is an alarm bell, or it is going long, or what should I do? Something like that is there or not? Can you please enlighten on that, sir?
Yeah, that's an interesting question. It generally depends on the setup. Like in our setup, the more the duration goes, we have to worry about more things like the hypothermia, the metabolic factors, fluid balance. A lot of things have to take into consideration for the case is going on for say 4 hours, 5 hours. In pediatric perspective, I'm talking. Adults, that's not a problem. Adults we can manage. Pediatric perspective is a bit more tricky because the balance is very, our margin of error is very less, and we have to be very careful about that. So maybe say, I have seen cases when I was in Amrita, which involving pediatric, not dentistry, I don't remember that. Usually, maxillofacial cases can be goes for hours, maybe like 8 hours, 10 hours. But we have to we have to, take it up. We cannot say, fine, I'm going to stop my anesthesia. But there are times in neurosurgery and all, we have to stop the surgeon. We cannot do it any further because the vitals are going down. We cannot. We'll be in trouble post-operatively. Maybe they can do it as a second stage at another point of time. We can ventilate the patient overnight. We can take up another time once the parameters settle. That has happened. But maybe 3-4 hours might be fine with a regular setup. Is there any dental procedures? I mean, regular dental procedures happening for that?
Sir,
leave the maxillofacial altogether.
Yes, sir. Yes, sir. Sir, that question depends upon the operator, sir. Also, because if the person is very specialized, you can finish entire full mouth even in 2 hours. They can finish because you have to be planned. That's not a question towards the anesthetist. The thing what sir said is maximum 3 to 4 hours for a pediatric patient would be the genuine thing. But let me tell you, as a pediatric dentist or a dentist who want to do it, you have to be well planned. Everything will be meticulously arranged, and everything is finished in maximum 3 hours maximum. I would suggest, from my experience point of view, full mouth rehabilitation should not be more than 3 hours. That includes crown, pulpectomy, extraction, whatever it is. So you should be well planned that the surgeons, the anesthetists will be happy that within under 3 hours if you do that. So that I think that question is answered. Devika, you can go ahead.
Thank you, sir. The next question is there any problem regarding the cognitive development of child undergoing multiple GAs?
Yeah, that's another area of gray area, I will say, because there are reports and studies about neurocognitive disorders developing in children who underwent anesthesia in their childhood in the 80s. But there are contradicting reports as well. But it's a multifactorial thing. You cannot blame anesthesia alone for that because a lot of things happen. And another thing, the anesthesia itself has evolved over the period of time. The molecules have changed, the medicines have changed, the standards have changed. So it's not a conclusive study or anything to say about this. I won't say yes or no because it's a gray area. I would like to believe it is no, because many patients we have seen, I mean, like they had, when you go through the history or the previous surgery and all, so many had gone through surgeries in the childhood, say appendectomy or maybe a tonsillectomy or maybe even say hernia childhood pediatric cases in the center. Many said, but they grow normally. I don't think it's a realistic issue.
Thank you, sir. Sir, the next request is the participant wants to know more about cleft palate cases in terms of administration of anesthesia.
Cleft palate is relatively less challenging. I will say cleft lip is more challenging to an anesthetist because the airway, we must ventilate and the intubation and all. Cleft lip creates a hindrance. You may not be able to get adequate mask seal while ventilating the child. Then palate per se is not a problem. Of course, all the issues associated with the pediatric anesthesia and the surgical airway surgeries are there. But per se, I won't say it is a particularly difficult, in a aesthetic perspective. Cleft lip, yes, it's also some challenges. Airway, to pass an endotracheal tube is not really difficult compared to cleft lip patients.
Thank you, sir. That was the last question of the day. Well, a big thank you for taking us to a ride on something that we have untouched, something that general practitioners don't really explore. Thank you so much for that. It was indeed an enlightening session. Thank you, dear candidates, for supporting us for all these years. And now I'd like to conclude. And so good night, take care, and we shall